There are now an estimated 47 million Americans without health insurance, and it's predicted that insurance costs could rise by as much as 9% every year. But affordable health care could be attainable.
Joining us today is Dr. Sam Marathe, who helped develop a working model for affordable health care in Hastings, a small town in St. Johns County that had amazing need. It was probably a magnification of the problems in every county, because there were people who didn't have access to insurance, didn't have the money to pay. So one of the big problems is they get sick, they go to the emergency room. Probably the least cost-effective way to handle your health care needs.
Absolutely.
So what happens? What is the whole thing the role that the emergency room is playing in making this a real problem when they really have these patients they have to help, but the cost gets so high because of that? How does that work?
You know, the emergency rooms in our nation have really become the de facto primary care clinic or the medical home for people who have no insurance, or even many of the Medicaid patients, because many of the Medicaid patients are having difficulty finding a physician, a primary care physician that will take them. So what has happened is, unfortunately, emergency rooms, as important as they are, when you truly need them, when you have true life-threatening emergencies, have become a walk-in clinic type of entities. And that is just a disproportionate or inappropriate use of emergency rooms for care that could be much better provided on an outpatient basis.
Not only the volume, but also the kind of care that they provide is not what these people are needing. Absolutely,
because these patients are requiring a trusted medical home where they have a relationship with a physician or a nurse practitioner or physician assistant, a provider, that is ongoing and continuous, not fractured or discontinuous care that they would receive in an emergency room. Emergency rooms are wonderful for heart attacks, strokes, major trauma, but they are not capable of following these people long term. They are not equipped to have these people come back and have their diabetes managed or their heart failure managed on a longitudinal manner. And they are unfortunately very expensive. Average cost in our particular community is about $1,500 for an ER visit. And average cost on an outpatient basis is, say, about one-tenth or one-twelfth of that. So you could see maybe 10 or 15 times more patients in an outpatient setting than in an emergency room. So I think that will improve the access tremendously. That's what we did in Hastings, which is a rural community of St. Augustine, Florida. St. Augustine is St. Johns County in Florida is a very affluent county, but it does have two areas of population that have people that are uninsured. Those two particular populations are primarily minority populations, African American populations, and the infant mortality in those populations is strikingly high. We are unfortunately one of the highest infant mortality rates in Northeast Florida.
Isn't it like 3 times?
It is more than 3.5 times. 18.2 per 1,000 births compared to, say, around 6.5 to 6.3 for the Caucasian population. And it doesn't have to be. One of the major reasons that infant mortality is so high, along with diabetes and stroke and cancer rate and cardiovascular disease rate, is because there is no access to continuous ongoing primary care in a trusted place where they have trust precedes treatment in healthcare. Because most of our patients wouldn't come to us, even if the clinic was open, if they did not feel comfortable. So I think one of our winning strategies, and it's not just a strategy, it's a way of life, is we treat people with respect, with dignity, and with compassion. And I think that goes a long way towards establishing long-term friendships and relationships. And therefore, we have really transformed some lives. And that's a tremendous reward for us in itself. Many of our patients have stayed out of the hospitals. There are less hospital admissions. They have less complications of diabetes. We have a diabetic education program, for example, with which we work with diabetic educators and social workers. And we also provide these patients what is a very valuable service. We call it patient navigation. They get an account executive that helps them to get their prescription drugs through pharmaceuticals, to get their transportation needs, to get their referrals to different providers. Many of the patients, especially the poor patients, have no idea. They don't have a tremendous amount of health literacy. They don't know how to navigate the system. They get lost in the system. Unfortunately, everybody ends up paying the price, because the taxpayers at the end of the day are going to have to pay for babies that are born underweight, that have mental defects, or that have other abnormalities. And in addition to the financial cost, the human cost of just having high health disparities in our community. So I think this model we brought together to not only improve the cost aspect of the equation, but also the human aspect.
A lot of what you're saying seems to be, for a layperson, it seems to be common sense. But we've had clinics in effect in this country for many centuries now, and so we've also had county health facilities that are now in place. Where have they missed the boat? Why haven't these organizations taken on some of the common sense and more patient-friendly attitudes that your clinic has? And conversely, why aren't you importing some of those into these county facilities now, utilizing a network that is in place?
Mm-hmm. I think it boils down to attitude and leadership and the mission of the organization, the vision. Now, we have a user predominant board. In other words, majority of our users, we have a not-for-profit organization that supervises our facilities, that gives us guidance, and that gives us strategic direction. And majority of our board members are our users of the clinic. So they have first-hand experience of the experience they have in the clinic. If they don't like the service, if they don't like the staff, if they don't like what they see, they report to us. And we have very few layers of bureaucracy. We are a very thin or very flat organization. So we respond within a day, or at the most within a week, we make changes. And what we have done is we have done what is called maybe a law of, we are using the law of comparative advantages. We are letting people do what they do best. We have a physician group that has been successful in our community, take care of the primary care of the patients. At the same time, we have this not-for-profit board, which has tremendous experience in, they are members of the community, so they understand the community needs, and they can give us the feedback, and they act as our oversight committee from the grounds up, and they also help us doing advocacy, getting funding, and serving as ambassadors for us with the governmental entities. And then we have the St. Johns County government, the board of directors. That have been the government. St. Johns County has been a good partner with us. That helps us fund and provide additional oversight for the program. And of course, we have good relationship with the hospitals. We have only one major hospital, Flagler Hospital. The hospital is very supportive of our patients because we have a winning formula. The hospital can decompress or depopulate its emergency room and therefore save on unnecessary expense. And in return, they give us diagnostic services and laboratory services. And I think the reason this model works is because everybody's local. People live there, and people work in the same community, and they are highly responsive to community needs. You know, if you have people working out of just traveling or transient providers or professionals that are only there for 8 hours and that are really disconnected from the community and have no accountability or transparency, then I think the system wouldn't work. And we are, of course, very glad to have University of Central Florida. I'm associated with the College of Health and Public Affairs, and we have a tremendous group of researchers, Professor Swan, Professor Zhang, Dr. Martin, Dr. Adams, that help us formulate a research formula so we can study our intervention, which is this unusual model of a practice-based research model, if you will, and it's a model of patient-centric healthcare. That's what we call it. In other words, we are putting the patient at the center of our equation, and we're going to look longitudinally to see if our outcomes are really better. We're going to measure and monitor diabetic outcomes, not only healthcare outcomes, but also quality of life issues. There is a big movement now in wanting to establish or examine the quality of life issues. How do people feel? Are they able to function better? Are they less sick? Is their attitude better? You know what I'm saying? How do they view the healthcare affecting them? So we are going to do this on not only a practical basis, but also empiric basis. We want to evaluate the evidence so that we can spread the word to other communities that may be looking for help.
A fascinating subject, an important subject, and we're going to talk more in just a few moments with Dr. Sam Marathe, and we're also going to update on your new medical school, the one at UCF, which we're all talking about in the news, so don't go away. We're back talking with Dr. Sam Marathe and getting a better idea about what's going on in St. Johns County, in particular Hastings, where we have a fascinating clinic that you have underway. And one of the things we were talking about is the subject of money. And you hate to kind of bring it up, but obviously that's kind of what makes the world turn these days. And you need to have some source of revenue. Are you surviving on the grants and the government? Or is this there's a way for the patients to become involved in this and perhaps participate even in a small way with their own health care?
Yeah, I think the reason this model works, it's a unique model, because we don't take care of only indigent patients. Our clinic is open to all comers. We see everybody. We see people with insurance, Medicare, Medicaid, Blue Cross, Aetna, as well as people, Medicaid is our big provider, as well as indigent patients. So I think we feel it serves two purposes. The reason the paying customers keep coming to us, although they don't have to, is because we provide good quality. And they don't feel like they're getting second-class health care. And most of our patients have continued to come to us for the last 7 years that we've been in Hastings and 25 years in St. Augustine. So that gives us a quality assurance check that if we start seeing less of our regular patients with insurance coming up to the clinic, that suggests to us that maybe we're falling down on the quality of care, because these people do not have to come to our clinic. They can go to other providers. And they also not only keep us keep our quality high, but they also help us subsidize the service that provide to indigents. So that is one of the important aspects of our model, is to provide all comers. We don't turn anybody away. In addition, we look for the county commission to serve the needs of the indigent patients. But if we did not have this model of a mixed model, where we have paying customers as well as non-paying customers, then the county would have to pay 100% of the clinic costs. And many of the clinic costs are fixed costs. The building has to be there. The 2 or the 3 staff members have to be there. And the physician has to be there so many hours a week just to provide access, even if he wasn't that busy. So there are sunk and fixed costs to a model. And right now the formula is roughly the clinic provides at least 50 or 60% of the cost through the paying customers, and the county is only providing 40 to 50% of the cost. In other words, it becomes cost effective or cost efficient for the county, because now their costs are reduced by half or more, and at the same time they're getting higher quality service. And the reason I say that is because the paying patients wouldn't have to come to our clinic. So I think this strategy works. Now, there was some suspicion or there was some concern whether patients who are paying customers would like to be in the same clinic that our migrant farm workers come. And we have found that to be unfounded. We have some millionaire farmers who in our community that come to our clinic and are sitting right next to the farmer, the farm worker who is basically penniless. And I think that kind of egalitarian approach has worked very well for us.
So really what sets your facility apart from everything else, and what people are coming to look and see, is you've got a collaboration, you've got a mix, you've got the paying and you've got the uninsured, and you've got a collaboration between government, for-profit, and non-profit board. So there's really a very good mix running the place. It's not all government, it's not all for-profit, it's not all non-profit.
Absolutely, and that's why we have bridges outside, because if we're all, say, government run, then typically, God love our county health department, but their physicians don't go to the hospital. They don't have admitting privilege. Typically they don't. So they do not understand or necessarily know what's going on in the for-profit world in a hospital. But we do go to the hospital. We see our patients not only as an outpatient, but as an inpatient, to provide continuity. And I think other important member of that team is a research team of University of Florida, Central Florida College of Health and Public Affairs. They help us with intellectual gravitas. For example, writing grants. We won a Blue Foundation grant for diabetic education, and we are looking to apply for more grants for infant mortality. So this is really a collaborative model. It really couldn't work. Healthcare is such a big issue that any one person, I don't think, has the genius to wave a magic wand and solve the problem. We all have to come together to bring what we do best to the table. The hospital does best in inpatient care and diagnostic services. So they come with that strength to the table. Our group is excellent in providing quality outpatient primary care. So we provide that. And then the government is good in oversight and providing funding for the indigents. And the user board, which is a voluntary board, is a tremendous asset to spread the word to because they are users and they're members of the community, and the public is looking to them to see whether are things going well in this clinic, to provide transparency, to provide ambassadorship. And I think we all worked very well together in symphony. So I call it a symphony model. And I think we found that to be a very attractive model. Now it's a lot of work to keep people together. We have to constantly communicate by multiple modes. We have to send emails, we have to have meetings, we have to have one-on-one meetings, conferences. But in the end, I think it's worth it, all that investment.
Sounds like it.
So much more to talk about, but we flat run out of time. We'll have to have you back another time in the future. Dr. Sam Marathe, thanks so much for joining us today.
Thank you both very much. I enjoyed being here.